What distinguishes narcolepsy type 1, type 2, and idiopathic hypersomnia? Can your diagnosis change? In today's podcast, I speak with Dr. Chad Ruoff about the latest research and perspectives on this topic. Dr. Chad Ruoff is an internal medicine physician specializing in sleep medicine. He is active in research and education and has authored numerous publications in sleep medicine on topics including sleep apnea and narcolepsy. Welcome to Project Sleep's podcast. Project Sleep is a 501c3 nonprofit organization dedicated to raising awareness and advocating for sleep health, sleep equity, and sleep disorders. I'm your host, Julie Flagar. We're so glad you're here as we work together towards making sleep cool. On this podcast, all guests express their own opinions. While medical diagnoses and treatment options are discussed for educational purposes, this information should not be taken as medical advice. Each person's experience is so unique, which is why it's so important to always consult your own medical team when making decisions about your own health. If you haven't done so yet, please hit the subscribe button so you never miss a Project Sleep podcast episode. And if you enjoy this podcast, please leave us a rating or review wherever you listen so that we can reach more listeners and raise more awareness. The Narcolepsy Nerd Alert series invites listeners to dive deeper into specific topics relevant to living with narcolepsy. For more on this topic, please check out our corresponding toolkit, available for free on our website to download, print, and share. The link to the toolkit and other Narcolepsy Nerd Alert topics is in the show notes, or you can go to project-sleep.com. Welcome, everybody. Today, we're really excited to talk about types of narcolepsy, trying to better understand narcolepsy type 1 versus type 2 versus idiopathic hypersomnia. It can be really, really confusing. And so we're just really excited to have this discussion, especially to have Dr. Ruoff walk us through this topic today. Hey, Dr. Ruoff.
Oh, hello. Thank you so much, Project Sleep, for having me. Excited to be here, and hopefully I can add some clarity and maybe a little bit of confusion to the picture, but hopefully at the end, a little bit more clarity for you, the patient and caregivers. So, really today we're going to be talking about narcolepsy type 1, type 2, and idiopathic hypersomnia. We're certainly not going to touch upon Klein-Levin syndrome. That is an entity in of itself. But, hypersomnia due to a medical disorder, hypersomnia due to a medication or substance, hypersomnia associated with a psychiatric disorder, these are the challenges in diagnosing and differentiating these top three. So while we won't talk about these, this is really what makes, coming up with a diagnosis challenging in collecting the clinical history and whatnot. Insufficient sleep, well, that's fairly self-explanatory. And it's certainly something we're concerned about more and more, just not getting enough sleep, social jet lag, not getting enough sleep during the week and then catching up on the weekend. And then the whole Sunday night, that's where some people might in general have trouble falling asleep that night because they spent the whole weekend catching up on sleep. And so trying to normalize that sleep across the 7-day week rather than the 2-day weekend playing catch up. And then normal variants, but then long sleeper, this is another one. So long sleepers is if they're given enough time to actually sleep and can ignore the societal pressures and whatnot, they feel fine if they get that. So, whether it's insufficient sleep that we're concerned about or long sleep, really the recommendation there is extend the sleep and see what it does for you. And with patients with hypersomnia, one of the really important things, like with insomnia patients, we want to define that optimal duration where they're not spending hours and hours laying in bed. So that makes the perception of sleep worse, right? The typical thing if someone's having trouble sleeping at night is to extend the time to get to that magical 7 to 8 hours of sleep. With hypersomnia, it's really what I recommend for patients is to define that optimal duration. What is that? Well, it's where if you go over that, you don't feel any better, but if you go under, you feel worse. And that can be really important, especially for some of the patients with long sleep or longer sleep, trying to get by with maybe an hour less of sleep every day. That's huge to get an hour back. If you can really diligently do this kind of trial and say, well, I usually get 10, but I think I feel the same with 9 actually. So that's really an important point. And the power of another hour during the day would be invaluable.
I was wondering too, where in the process of trying to diagnose someone with a hypersomnia, do you think that clinicians are considering other things outside of hypersomnias as well? Like other autoimmune conditions that might cause We always think of how it takes so long for anyone with these conditions to get to a sleep specialist. But at the same time, I have heard of some cases where someone ended up with a lupus diagnosis that had been missed for many years and actually got on treatment for that and felt that their sleepiness resolved. So do you know how much they consider other things too?
I think it's important. And when I see a patient, I always encourage patients to talk about their fatigue, sleepiness with all healthcare providers and make sure that they're not missing something. I mean, I've had certainly that can be lupus, MS. MS has rampant fatigue, which fatigue and sleepiness, sometimes even with a person in front of you when you're trying to dissect, is it fatigue or is it sleepiness? Sometimes it can be challenging. Yes, sleepiness is the tendency to fall asleep, and fatigue is this tired, exhausted feeling, but not nodding off. But gosh, sometimes it can be challenging to tease those two apart. But yeah, I agree. You have to look for other conditions too, especially, when we see the word idiopathic, right? Idiopathic means that we don't understand why you have this condition, but you have this condition. And so this is where a lot of medical entities start, is as a syndrome, to place bins of patients that have similar symptoms and whatnot and study them and try to figure out, make that pool as homogeneous as possible so we can learn from that group of patients and then come up with like narcolepsy type 1 with hypercretin orexin deficiency, right? A robust biologically confirmed entity, but it has to start somewhere. But idiopathic, so just because you've been diagnosed with idiopathic hypersomnia, I wouldn't go through life saying, I'm sleepy because I have idiopathic hypersomnia. We just have to remind ourselves that it's idiopathic. We don't have a biologically confirmed understanding the pathophysiology underlying idiopathic hypersomnia. So, if you follow those patients for time, maybe they would end up being diagnosed with something else. Just keep that in the back of your minds moving forward. Yeah, I don't know if that addressed your question, but you pretty much answered it for me. So next thing, so what are the symptoms when I'm seeing a patient that might have narcolepsy, IH, or just hypersomnolent that I look for? So I always make sure that I address all 5 of these: excessive daytime sleepiness, which, like we already just talked about, that can be difficult to differentiate sleepiness versus fatigue, kind of a spectrum. Cataplexy, and really moving towards defining cataplexy as typical versus atypical, which we'll probably touch on later. Sleep-related hallucinations, right? Hear things, feel things, see things as you fall asleep or wake up. Hypnagogic or hypnopompic hallucinations. Sleep paralysis, literally the inability to move even a finger as you fall asleep, as someone falls asleep or wakes up. This can be often misconstrued as a compression neuropathy where, you're sleeping on your arm and you wake up and your arm, you can't feel it and whatnot. That's not sleep paralysis. In my experience, within a few seconds of talking to a patient about sleep paralysis, they usually will offer this up on their own, that, oh my goodness, yes, I have that. The first couple of times, it scared me to, half to death. I didn't know what was going on. And then you ask about sleep duration, and oftentimes they'll say, oh, it feels like it lasts forever, but it's probably seconds, or they just have a very challenging time characterizing the duration. And then disrupted nighttime sleep, there's really no well-defined clinical criteria for this, objective or subjective, but it's just really fragmented sleep during the night. So struggling to stay awake during the daytime, and maybe struggling, this is exaggerated, but struggling to stay asleep in a consolidated fashion at night. And then some other symptoms when evaluating for this is, of course, sleep inertia, sleep drunkenness. This is first thing when a patient gets up, there's multiple alarm clocks, they have trouble waking up, extremely groggy. The somnolence is definitely more impactful in the morning hours when they're trying to get up. Sleep duration, long sleep, normal sleep, and the restorative nature of naps. Sometimes I'll look at that as well. So what are our tools? This is probably, of this talk today, I think this is probably one of the more important just for patient care, advocating for yourself. So just know what's out there, and make sure if you're uncertain about your diagnosis, make sure that you've kind of at least engaged your healthcare providers to make sure that one of these tests isn't suitable for your condition or your situation. So a solid history. I would recommend that a loved one, caregiver, especially at that new first consult, always shows up with the patient, just to establish a rapport with patient, family member. It does so much for the healthcare provider. in hearing not only from the patient, but also a loved one, friend, family member. So that's just a tip, I think, that can really help accelerate your care and get things started. There's all kinds of subjective scales. I mean, there's subjective, the classic one that probably every patient has had is the Epworth Sleepiness Scale. I don't know how many times I've had an Epworth sleep. The highest number is 24, right? How likely to fall asleep in this situation or that situation? I've had patients, and it goes both ways. They have an Epworth of 20, and I'm like, my goodness, you can't stay awake while reading. To 3, high chance of falling asleep. Oh, well, no, I don't actually fall asleep. So they're scales, they're not the end all be all, but they can be helpful. But what's a high chance of falling asleep for one person might not be at all for the next. And so they have their limitations, but important. Actigraphy, probably underutilized for a variety of reasons we won't delve into, but I think that we need to increase our use in the clinic of actigraphy. Actigraphy is nothing more than a medical grade, accelerometer placed on the non-dominant hand typically, and wearing it for 1 or 2 weeks. The longer, the better. Sleep diary, just, recording your sleep habits. What time do you go to sleep? How long does it take you to fall asleep? Naps, etc. And then, of course, a core part of the diagnostic criteria, the PSG, the overnight sleep study, followed by the MSLT. The overnight sleep study is really to rule out other conditions, namely sleep apnea, make sure there's a relatively normal sleep architecture, looking very closely to see if there's a sleep onset REM period where someone might go into REM sleep very quickly. And then the MSLT, how I describe this to patients and other healthcare providers that aren't in sleep is all we're doing is a series of 4 to 5 naps, ideally 5, and answering some very simple questions. Do you fall asleep on each nap? 8, 10, 12, 2, 4. If you do, how long does it take you to fall asleep? And if you do fall asleep, do you go into REM sleep? That's it. We tally that up. That's how we handle MSLT data. We tally that up, and there's diagnostic criteria for narcolepsy and IH. A blood test for LHLA, DQB 10602. So this is not diagnostic. For the sake of this talk, I want you to leave today, or when you put your head on the pillow, just think that patients with classic type 1 narcolepsy, just think of them as 100% of them are HLA positive, narcolepsy type 1, because it really simplifies this discussion. So if someone has a concern for cataplexy, right? So typically cataplexy is going to be type 1 narcolepsy. And if we were to do a spinal tap, most likely they would be deficient in orexin or hypercretin. So if there's ever a concern as to whether this is cataplexy or typical versus atypical cataplexy, which we'll go into a little bit, I'm sure later, this is a great place for your healthcare provider and you to advocate. I want to get an HLA test. I want to see what this is. If it's negative, it really would side with the fact that if we were to do a spinal tap, that the orexin level would come back normal. So in type 1 narcolepsy, there's orexin deficiency. If we check orexin, it's less than 110. And so it's great if there's a challenging case trying to differentiate, is this cataplexy, is this not? So for anyone, with a questionable diagnosis of cataplexy, even in your heart of hearts, you're wondering, do I have cataplexy? I have this in this situation, but is it? My healthcare provider isn't sure. An HLA test is a great way to go. And then if it's positive, then you might entertain the idea of talking to your healthcare provider about the pros and cons of moving to the next step, which would be an orexin test. This is finally commercially available, and so that's certainly important. Your healthcare provider just has to do a little bit of work to get it done, but it's commercially available.
For the HLA marker,
yeah,
isn't it kind of a pretty simple blood test too?
Oh my gosh, yeah. So it's so simple. So
any sleep doctor should be able to do this, right?
Unequivocally, yeah, absolutely. Widely available. They just need to make sure that they're doing the right one, that they're not actually doing the one for celiac, or it just says specifically. So at my institution, it literally says HLA test for narcolepsy. So yeah, it's widely available. There's, at least in the United States, this should be available everywhere.
Okay. Just as I feel like it is I know it's not diagnostic in and of itself, but it's a good clue. And I'm often surprised how many people their doctors didn't ever look at this. And so I'm glad you have highlighted it here as something that a patient could probably ask their doctor for if they're in this confusing middle ground and not sure.
And it's an important point. So HLA, it varies by ethnicity, but if you just go with, say, maybe 25% of the general population walks around with this HLA positivity. So just because you're positive doesn't immediately put you into the type 1 narcolepsy bin, but it doesn't exclude. If you're negative, it really, just keeping it very simplistic, algorithm, it really almost excludes orexin deficiency. So it immediately kind of makes the narcolepsy type 2 diagnosis, could make it more homogeneous, which is the goal, in that if you're negative, then you're more certain to be type 2. It does vary by ethnicity. So like African Americans, they have a high positivity. Japanese ancestry have a low positivity of this. So it can be clinically, it's very helpful when it's negative. If it's a challenging case of atypical cataplexy. And don't forget, there can always be some psychiatry. Antidepressants, for example, are a great treatment potentially for cataplexy. So it's always this debate as to whether, oh my goodness, sleepiness started 3 years ago. Patient's been on an antidepressant for 10 years. Could this antidepressant be masking the cataplexy? And that's where this might come into play, doing the HLA test, but widely available. And if you're confused about your diagnosis, your healthcare provider isn't sure, that might be a great place, especially if there's questions of cataplexy.
One other question, why is the actigraphy helpful? I am just not familiar with why that would be a helpful tool.
Yeah, great question. So going back to the differential, right? So we want to look at insufficient sleep. We want to look for long sleep, potentially. So it immediately will give us an objective assessment of that. It also will look at, is the patient not getting enough sleep during the week and then playing catch up on the weekend? If the MSLT is negative, and one of the core complaints of the patient is sleepiness and long sleep, they're sleeping long hours, then actigraphy is a way that you can actually cinch, according to ICSD-3, a diagnosis of idiopathic hypersomnia. So someone could have a negative MSLT. Their MSLT does not suggest CNS hypersomnia, like narcolepsy, idiopathic hypersomnia, but while wearing one of these for 2 weeks, or coming in for an ad lib 24-hour, 48-hour sleep study, which is near impossible in the United States unless it's research, you document that they're sleeping 660 minutes on average each night, which is a lot. So that's 10, 11 hours of sleep a night on average. But that's where it can be very helpful, and it can actually lead to an ICSD-3 diagnosis of idiopathic hypersomnia. But it's also used great, for ruling out things too, right? Is the patient just insufficient sleep? Are they all over the map, going to bed late one night, early the next? They have this self-inflicted perpetual jet lag. They don't know if they're coming or going. So it can be very helpful. Diagnostic criteria. So for type 1 narcolepsy, what do we need here? So we need sleepiness for at least 3 months, and the presence of one or both of the following. So cataplexy and a positive MSLT. So I inevitably will say positive MSLT. So what does that mean? That means on those 5 naps, on average, the patient falls asleep in less than 8 minutes, less than equal to 8 minutes. And on 2 of the naps, they immediately go into REM sleep within 15 minutes. And so we term that a SOREM, a sleep onset REM period. So less than equal to 8 minutes average sleep latency of falling asleep, and then going into 2 or more REMs on the naps. And also on the overnight test, if they slip into dream sleep within 15 minutes, that can count towards this. This number, this 8 minutes used to be 5 minutes. I won't go back too far as historically all the changes, but it used to be 5 minutes, but it was increased to 8 minutes to increase the sensitivity, and it maintained about the same level of specificity. Or a lumbar puncture to check for orexin or hypocretin. Sorry, we love, in the medical community, we like to have at least 2 names for everything. So hypocretin, orexin. And so that can be diagnostic for type 1 narcolepsy as well, without cataplexy. You don't have, because it's one or both. So someone could not have cataplexy, but have orexin deficiency and be diagnosed with type 1 narcolepsy. Narcolepsy type 2. So same thing, first thing, at least 3 months of sleepiness, a positive MSLT. The overnight study, it's always important to have an overnight study followed by a daytime MSLT. That is the standard. So anyone out there that had them separate, that's a problem. And cataplexy is not present. And if a hypocretin lumbar puncture was done to check orexin levels, it's normal, or more than 110. And the sleepiness complaint is better explained by something else. This is what Julie talked about. Is there another condition? Are there any findings on the neurologic exam? any medical disorder, medication, psychiatric illnesses that might be contributing. Is there a circadian rhythm? Is there a delayed sleep phase, going to bed very, very late and then waking up, later in the day? But yet societal pressures force those folks or us to, wake up early. That's the goal here in society, it seems. So looking for other possible explanations. Idiopathic hypersomnia. So again, sleepiness for 3 months, no cataplexy. This is the difference right here. So right now in the current diagnostic criteria, idiopathic hypersomnia versus narcolepsy is simply differentiated by number of SOREMs, sleep onset REM periods. So both narcolepsy and idiopathic hypersomnia have to, on the MSLT, have to fall asleep on average in less than equal to 8 minutes. But with IH, there's not a REM propensity. So they have less out of all those 5 naps, there's less than 2. So there can be 1 sleep onset REM period, but they can't have 2. If they have 2, then that would put them in a narcolepsy bin. So this is really the differentiating factor between narcolepsy type 2 and IH. And the presence of at least one of the following. This is to your question, Julie, the actigraphy. So actigraphy, if the actigraphy watch, the glorified medical grade accelerometer, demonstrates more than 666 minutes, or you're fortunate enough to get a 24-hour overnight or 24-hour PSG polysomnogram, if you can cinch this 660, this is, according to ICSD-3, supports a diagnosis of idiopathic hypersomnia. Hence my point that I don't think that we're doing actigraphy enough. And then again, kind of the last number similar to the narcolepsy is looking for other potential causes that might better explain the sleepiness. So what are we left with? So we're left with kind of 2 things. We're left with narcolepsy, which we now differentiate between narcolepsy type 1, that typically can have cataplexy, but it doesn't have to have cataplexy. And if a spinal tap is done, they're orexin deficient, hypercretin deficient. And then idiopathic hypersomnia, how I differentiate in the clinic. So sleepiness with narcolepsy and sleepiness, brain fog. Brain fog comes up more in the idiopathic hypersomnia literature, but certainly this is not absolute, just kind of a clinical phenotype I'm just trying to paint here. With cataplexy, so we're trying to get in, missed an L here, but typical versus atypical cataplexy versus no cataplexy, right? So ideally with no cataplexy, that's more of a narcolepsy type 2. In IH, of course, no cataplexy. The restorative nature of sleep and naps, more so with narcolepsy phenotype, less so with IH, right? So non-restorative, long periods of sleep, naps are less refreshing, which in some instances, when you get this history, it's like, why did you take the nap to begin with? Because they almost wake up worse off than before they took a nap. And it sometimes can last hours with IH, typically. Again, wake up feeling refreshed. The sleep inertia, sleep and drunkenness in the IH phenotype, that's certainly a big one. A clue. More of the REM-related phenomenon, the hallucinations we talked of, the paralysis, disrupted nighttime sleep, that fits more of a narcolepsy phenotype. And then IH more classically, there's no REM-related phenomena, but REM-related phenomena can occur in the general population. So just because someone has sleep paralysis does not mean, oh my goodness, they have narcolepsy. That's an important point. And depending upon the study you quote, maybe 5, 10+% of the general population have experienced sleep paralysis, and even higher with the hallucinations. So just because someone has sleep paralysis hallucinations and they're not sleepy does not mean, oh my goodness, I need to go see a sleep doctor to be evaluated for narcolepsy. But if they have those and they're sleepy, then you might have something there. Comorbid sleep disorders. So in the narcolepsy phenotype, more REM behavior disorder, acting out their dreams, leg twitches, sleep apnea. In the IH, really kind of the cardinal rule is to rule out other sleep disorders. Because we don't understand the underlying pathophysiology, it's difficult, at least for me, to say that in IH, there's this comorbid condition. Similar to the narcolepsy type 2, until we understand the pathophysiologic underpinnings, it's difficult to say, oh, there's comorbid conditions. But in NT1, there's been plenty of comorbidities described and replicated: obesity, nocturnal eating, precocious puberty, psychiatric illnesses. And with IH, you just want to be, and narcolepsy type 2, you just want to make sure that, or I question that the comorbidities, they might be actually contributing to the clinical picture. So psychiatric overtones in IH and narcolepsy type 2. Autonomic symptoms in the IH phenotype. For some reason, a lot of the patients that I see have some autonomic symptoms and ultimately go on to be diagnosed with IH. So kind of putting these into bins. Certainly, I feel like there is a clinical phenotype when I'm seeing evaluating patients for hypersomnia. But then ultimately, we're left with the MSLT to differentiate these two. Another important point, and I've highlighted already, in patients with narcolepsy without cataplexy, so this is type 2 narcolepsy, if they undergo a spinal tap, if you had the HLA, so you had a question of, do I have type 1 or whatnot, or do I have atypical cataplexy, and you got the HLA test, your healthcare provider ordered it for you, and it were positive, in some publications, if you did a spinal tap, even though you don't have cataplexy, 15 to 20% of those patients have a chance of being found to be orexin deficient. What does that do? Well, that then changes your diagnosis to narcolepsy type 1. And I think this is an important point to mention as well. So in this study by Andlar et al., African Americans were 4.5-fold more likely to be found to have orexin deficiency without cataplexy compared to Caucasians. So clinically, if I'm evaluating a patient with a CNS hypersomnia and they're African American, I'm paying very close attention to the presence or absence or atypical cataplexy, and really thinking about this after the MSLT is performed, that maybe we should be doing HLA and at least talking about orexin testing. My goal as a clinician is to try to pull out as much, just to, if we have a chance to do HLA and find orexin deficiency, we should be doing that to better define these conditions for patients, family members, and for prognosis. So what are some of the MSLT challenges, the daytime study? So these are the challenges. So the MSLT is positive for narcolepsy in the general population in 6 out of 100 men and 1 out of 100 women. That's a problem. So you run the test on a random sample of the general population of 100 patients, 6 men and 1 woman are going to be positive for narcolepsy, regardless of symptoms. And
that's just the general population?
General population. This is not people presenting for daytime sleepiness.
They would go, and remind us, that would be falling asleep within 8 minutes?
Less than equal to 8 minutes and having at least 2 dream periods.
Wow.
So this gets to false positives, right? So if someone comes in complaining about fatigue and their GP sends them to a sleep doctor and they just are doing MSLTs a lot, there is a true risk based on this general population data to have false positive diagnosis. Maybe this isn't narcolepsy. So to your point, Julie, it's always, making sure that if there are other symptoms, delve into those other symptoms and make sure that there's not another explanation out there, like you alluded to, lupus or something like that. And in the general population, the MSLT, so falling asleep less than 8 minutes, that was positive in these studies in about 22% of the general population. That's high. Remember, that's the diagnostic criteria for idiopathic hypersomnia, less than equal to 8 minutes. And so that's, if we just, general population had 100 patients come in from the general population, that the 23% of them would meet this criteria. Shift workers. So, and I use shift workers loosely. So if someone is having this social jet lag of being insufficient with their sleep during the week and then catching up on the weekend, that's essentially kind of a social jet lag is a kind of a form of, well, at least a circadian, irregularity. And so that increases the likelihood potentially of a positive MSLT, 30 times more likely with shift workers to have a positive MSLT. Antidepressant use, 11 times more likely to have a positive MSLT, positive meaning for narcolepsy. And speaking to the IH community, in this study, and they really leveraged the power of doing ad lib overnight sleep testing, 24, 48 hours. 44% and 39%, 2 different studies here, of patients with IH had a mean sleep latency of greater than equal to 8 minutes. And so with additional tests, a 24-hour sleep study, they were able to demonstrate a diagnosis of IH. But if that clinician, if their healthcare providers had only done the overnight test and the MSLT, they would have been missed. And so this is where in the US, we don't have the luxury of 24-hour sleep tests and stuff yet. Actigraphy can be helpful. And in 71% of the IH folks with long sleep, 71% had a mean sleep latency of greater than equal to 8 minutes. So on one hand, you have in the general population, 22% meeting this criteria, but in these folks, they're not meeting this criteria. And so then over the last, 5 years or so, the another thing that's been called into question is the repeatability. How how robust is this MSLT? So that if you do it today and then you do it 2 years, 3 years from now, does it end up with the same result? And so
I meant to say this in the beginning, your paper and your work in this area is, why we really wanted to have you as part of this discussion because of this research you did. And
yeah,
I think it's really helpful for people to understand because they're often like, how could my diagnosis change? And thinking it's just them. And guys, it's not just you if your diagnosis is changing. So anyway, go ahead. But I meant to say that at the beginning.
Yeah. And so probably I should have probably presented this other information after this as a potential explanation as to why this is occurring, or why we found this. So 3 different studies. So it's been replicated. Now, all these studies are retrospective. That is a huge limitation. So this isn't something prospective that I see a patient, we do an overnight test in MSLT, and then prescriptively we do a repeat MSLT 6 months, a year later, and see is the repeatability of that stable across time. So a big question and limitation is, why was the study repeated in these data? But what we found across 3 different studies is that the MSLT in type 1 narcolepsy with cataplexy or hypocretin orexin deficiency, or typical cataplexy in HLA positive, that blood test positive, it's pretty retest, the repeatability of it, 91% of folks that have a positive MSLT on the first positive test on the first MSLT, they'll go on to have another one that's positive. That's what you want to see, right? So when you talk to loved ones and stuff about your condition, you want to say, yeah, I had an MSLT and it showed this, and it's a repeatable, reliable test. And if I did it in 6 months, it'd be positive again. That's what you want to see. And in this other group, it was 81% likely to be repeat. If you did a repeat, it would be positive again. Whereas in narcolepsy type 2 and IH, it's not a stable phenotype. If a patient is rendered a diagnosis of narcolepsy type 2, they meet the MSLT criteria, they don't have cataplexy, if they have the spinal tap and their orexin or hypocretin is normal, if you repeat that test, that MSLT, it could change. It could go negative. It can switch to idiopathic hypersomnia and vice versa. Same thing goes with idiopathic hypersomnia. So a patient has a daytime test, they're falling asleep less than equal to 8 minutes. 6 months, a year, 2 years, 3 years later, they repeat it, it'll be negative. And so this is extremely frustrating, not only for patients, but healthcare providers. And this is the biggest challenge that we face in evaluating CNS hypersomnias. The MSLT is our best objective test to measure sleepability, the likelihood if someone's told to fall asleep to try to fall asleep. But there's huge limitations, at least in type 2 narcolepsy and IH. And so while I believe just clinically, my view is that there's a clinical phenotype, I think, with narcolepsy type 2 versus IH, certainly with IH with long sleep. The MSLT, I don't know if that's really the test in the future that we should be using to differentiate these conditions as we're doing today. So what to do, if you have an MSLT and, your loved ones around you and everyone, they strongly suspect the CNS hypersomnia, there's sleepiness, you see it with your own eyes, family members. The question is to repeat the test or not. Certainly for clinical care and getting access to things, it can be very helpful if the MSLT wasn't what was expected. It was negative, it was positive for IH. So this is a clinical matter. But from a research perspective or just a diagnostic issue, this is troubling. The MSLT is not a reliable test according to these 3 different studies here. So these are 3 different, research groups with different patients that came to this very similar conclusions here. So that's the challenge. So the real question is, where do we go from here? So the most robust objective test we have is not repeatable, at least in this data here.
And I feel like it's just not fair to patients to have to feel like you're going into an MSLT and just hoping that your brain goes into the right forms, and because everyone's experience is very real, and their symptoms are real. Like you said, family members, it's real. And so this is kind of feels like you're throwing a dart at a dartboard to see if you could get an MSLT result that's going to be helpful for medication and coverage.
Yeah. And so Now, some other explanations, right? So we talked about shift work that has a high likelihood of a positive MSLT, right? 30-fold increased risk. So that's why, that we recently came out with new guidelines for the MSLT. And it's just so important that healthcare providers, but also patients kind of advocate, and Project Sleep and everything, that we're doing the overnight test and the MSLT to a T. So we're getting the actigraphy for 2 weeks. You're bringing family member, caregiver, friend, whatever, loved ones to those appointments to establish that patient-doctor relationship, that rapport. Visit one. It's so critical because of these issues. Some might argue that we should be really diagnosing this based on symptomatology, which is challenging, because we really like to have an objective test to say, aha, this test is positive. But that's out there, that we should rely more upon symptoms, which having caregivers and patients and family members and friends there is very important in that situation. I'm not suggesting that we go to that, but just emphasizing, yeah, it's challenging. So where do we go from here, right? And I don't have the answer. So what I didn't show here is, so historically, right? So in like 2000, that's when it was discovered that narcolepsy in humans was due to narcolepsy type 1 with cataplexy was due to orexin deficiency, hypercretin deficiency. So before then, we had HLA, some of these HLA findings that in narcolepsy with cataplexy, they were more positive for HLA markers. But it wasn't until 2000 where we were able to take these patients and say, look, aha, we have a biologically confirmed entity here. So now we can define this group as a homogeneous group. So we pull those out. And my feeling is, and this can be debated back and forth, but that really the next step is to what to do with these patients that have an MSLT that on one time it shows narcolepsy type 2 and the next time it shows IH and vice versa. What do we do with those patients? I think the first thing is that we pull, what else can we pull out? So I highlighted, so African Americans, narcolepsy type 2, more likely not to have cataplexy and yet have orexin deficiency. Take those out of there, right? So be more, when you're evaluating patients or you're advocating for a loved one, keep that in mind. And then long sleep. So there's been some of these really nice cluster analysis looking at, symptomatology and clustering them. And it does appear idiopathic hypersomnia with long sleep, my belief based on the data, is that that's a pretty homogeneous group. So I think that intuitively, that's the next step, is to take those patients and kind of put them in their own diagnostic entity, which is why I think that we're not doing enough actigraphy, not doing enough prolonged PSG overnight sleep testing to define that group of patients, capture that group of patients. And then what we're left with is this, potentially is, in my study, I think maybe 30% of the type 2 narcolepsy patients repeated both times positive. So maybe perhaps, I'm not suggesting that we do 2 MSLTs to define this strong, repeatable, reliable phenotype, but maybe that is a reliable phenotype, where if you have patients with 2 positive MSLTs for narcolepsy, maybe that's a phenotype that we can study and learn from. So, there's been other studies looking at these conditions using tools like imaging. And a lot of the imaging findings in CNS hypersomnias are not consistent. And it's probably because we're not phenotyping these patients into homogeneous groups. So until we can do that, we really can't advance the field, I feel like.
Yeah, I mean, there's a few proposals out right now about where to go from here. And we'll make sure that those are in our toolkit. And, for our nerds that love reading papers, they're interesting. And I think we will see some change when they do the next ICD international classification.
Hopefully.
Yeah, because it just doesn't seem right that people should feel like, you get attached to a disease name, like, okay, I figured it out. And these are already very stigmatized conditions. And then to have your disease name change, it is a big change in people's sense of identity, even though I think from a research side, we say, you're still part of our club. Don't worry. You're part of our community. Your symptoms are real. You're having a real experience. And,
Absolutely.
it shouldn't be able to switch that easily, I think, on people, just from a personal perspective. I did mention atypical cataplexy, and I'm not so familiar with the use of that term. So
yeah. Yeah. So, the clinically, when I'm asking this question, does anything unusual happen with laughter, saying something funny, coming up with a witty joke? That's usually how I ask it to a patient. And typically, a patient that doesn't have a CNS hypersomnia, doesn't have, cataplexy, they look at me dumbfounded, like, what in the world? Does anything happen? And typically the jokester says, oh, no one laughs. I'm telling a joke, no one laughs. That's what happens. I'm like, ha ha ha. But the other thing that happens often is like, well, what do you mean? I mean, I laugh, so leading them, not leading them, asking in a very unbiased basis is really important. But typically, after they're kind of looking at me like puzzled, like this guy's weird, some weird questions there. I'm like, such as jaw sagging, knees buckling, falling to the ground, those kinds of things. And, in the general clinic, 99.99% say, oh, no, no, I don't do that. Occasionally, you might get someone that says, well, yeah, when I laugh really hard or something like that, something might happen. Like I laugh, the classic kind of cliche thing of I laughed so hard I fell to the ground, right? So that's a positive emotion, laughter, right? So there's negative emotions too, right? Anger, startled, scared. These are all negative emotions. So typical cataplexy is typically triggered by a positive emotion. So classically, laughter. That is the right trigger. The duration is another thing, right? So duration, the typical duration is pretty short. And I'm not the one that should be talking to that. I mean, that's the patients that should be talking to you about that. But it's atypical for cataplexy to go on for prolonged periods of times, hours. If that's there, then we like to hear that, oh, there's also, short, the typical is a short attack. It's not typical to always fall to the ground, not to have any warning, have an injury. So that would be atypical. It can happen, but it's not typical. And there should also be these more typical episodes triggered by a positive emotion. So the classic thing, short duration, triggered by a positive emotion, typically, affecting the neck, the shoulders, the head bobbing, maybe a little bit of knee buckling. And it's not so rapid that there's not time to prevent injury. It's almost, I always kind of equate it to like an accordion collapse. And so that's typical versus atypical. So atypical would be a negative emotion only, long duration, those kinds of things. Whereas a typical would be a positive emotion, you know, 10 seconds, short duration, those sort of things.
I feel like I hear from a lot of people very subtle, even more subtle than the jaw dropping. People saying like like having to sort of pause, and this is true to my experience living with severe cataplexy, is that when I'm on medication, kind of those are kind of your internal coping is like, oh, I kind of just kind of like pause myself to not make it worse, sort of. Or someone had described that they lose their smile. They say, oh, you lose your smile when you laugh. And that's because she's having a hard time with her jaw, but not necessarily like dropping open. So it is really interesting to think about. I like how you present more from the idea of like what happens when you laugh, as opposed to going from the perspective, like, are you falling down? Because I think there's a lot of subtlety in many people that have mild cataplexy. Yeah.
Right.
I'd argue personally that the idea of positive emotions being typical is a little bit of a misnomer. I think that is because it's unique. Whereas, and I've talked to Dr. Scammell about this, negative emotions could cause, some sort of like fainting, other things.
Right.
And so the positive emotions are more unique to cataplexy, but I don't think that that necessarily means that they're entirely more typical. I know annoyance and were very early ones for me.
Yeah. I think it's just if there are negative, it's a more of a typical case if there's also positive. If there's only negative and that's it, that would be classified as atypical. Now, regardless if that's typical or atypical, if it's as we know it now, it's kind of on the atypical, and that's where the HLA testing that we talked about earlier can come into play. The orexin testing, especially if you in your heart as a patient say, this is cataplexy, then engage, advocate for yourself, and go down this path of HLA, especially if your MSLT is negative. My goodness gracious.
You talked a lot about the spinal tab, or the hypocretin. Yes, well, there's a real word for it. What did you call it? The
Orexin or hypercretin,
well, the spinal tab thing. It's used more in Europe now than the US. It's not obviously a comfortable procedure to have done. So Do you think there's any hope for some other ways of measuring hypocretin, or
Yeah, it
is
would
this
be
kind of
great.
the main one?
It would revolutionize evaluation and diagnosis if we had a blood test. But that's an important point. The HLA is not diagnostic, right? That we talked about. There's not really a blood test that diagnoses narcolepsy or IH yet. So I'm not aware of, any developments in this space. There's nothing coming to us, in the near future. That's for sure.
Right. So do you think that we will that there's going to be increased use of that spinal tab in the US?
So it's been part of our diagnostic criteria since 2014, right? So 2000-ish, this is how research unfolds. So 2000, we find orexin deficiency in humans for narcolepsy, right? 2014, it finally makes it into the diagnostic criteria. 2019, at least in the United States, it's now commercially available. That's great that it's now commercially available, but it took us 19 years to get it to where it's not just research, it's commercially available.
Thank you so much, Dr. Ruoff, for coming in and tackling this challenging topic. I know it's a lot. Really quick, just want to, of course, mention the patient organizations because they are incredible and they're important and they have so many different great resources. So especially when you're thinking about hypersomnia, check out the Hypersomnia Foundation, has so many incredible online resources. Narcolepsy Network, of course, us, and Wake Up Narcolepsy has a lot going on all throughout the year. So check these out. International ones are online. Everybody, thank you, Dr. Ruoff.
Thank you so much.
All right, bye for now.
The Project Sleep podcast is produced by Carver Sound Productions. For more information on podcast production services, visit carversoundproductions.com.